So hopefully that gave you a sense of how to perform ventilations, and you saw how we do it in the healthcare setting. I want to show you now a real case of cardiac arrest recorded using a specialized defibrillator that records both ventilations and compressions. The reason why I show you this is we're going to use this as the basis for some of the data I will share with you about the quality of CPR as performed by healthcare providers. And I think you'll find this very intriguing. So this is an actual cardiac arrest, and in the top tracing, those little red humps represent breaths being delivered by a rescuer. In the middle is the ECG, or electrocardiogram, or electrical recording of the heart. And in the bottom tracing are compressions. Each vertical line there represents an individual compression. The depth of each of those little valleys represents the depth of each compression. So now let's roll the tape. So this is a patient in cardiac arrest. They're receiving compressions and breaths, and then the team stops compressions. And they do that because they have to, because they want to look at the ECG to decide if this rhythm needs a defibrillation, a shock. And you'll remember from our first lecture, we talked about shockable and non-shockable rhythms, that some cardiac arrests need a shock and some do not. Well, I'll just tell you that this one did, because this rhythm is ventricular fibrillation, or VFib for short. So the rescuers quickly move on to deliver a shock, and those little blue lines and notations in the top tracing shows the shock being delivered. And now you notice that the rhythm has changed. Those of you who are not healthcare providers can probably see that that middle tracing does look different now. Healthcare providers, you may be guessing what's going on. And indeed, compressions are once again started because the team recognizes now ventricular tachycardia, or VTach, another cardiac arrest rhythm. Now I only show you this as an example. This was an actual real cardiac arrest that we participated in, and it shows you the sort of data you can obtain if you record ventilations and compressions. We used a tool like this to study CPR in the hospital to ask some fundamental questions about quality. And what I want to share with you now are some results from our research group looking at healthcare providers, doctors and nurses, providing CPR in the hospital. And this is going to be what's called a frequency histogram, or said another way, the distribution of chest compression rates in a series of cardiac arrests. Now you see on the x-axis there chest compression rates. They go from very low to very high. You're going to see a bunch of bars appear. The height of the bar represents the commonness, if you will, the frequency of that rate being delivered. Now mind you, these are all healthcare professionals who are trained and certified in CPR. I'll also tell you that chest compression rates should be delivered at a rate of 100 per minute. So, if the rescuers are performing CPR perfectly, you would only expect bars around 100, maybe 90, maybe 110, but they should cluster around that rate. This is what we found. Not clustered around that rate, but rather a wide distribution of chest compression rates. And that vertical line is to highlight the fact that that's where they should be. And you can readily see that chest compression rates are all over the place. Indeed, a third of the time, the chest compression rates are less than 80. And I'll tell you that in the animal lab, when you perform chest compressions on a pig or dog at a rate of less than 80, very few of the animals survive. So this is a real problem. These are healthcare providers who are certified in CPR. This should alarm you. This is a problem in the way that CPR is performed and speaks to some of this variability. After all, if this is what healthcare providers are doing, and this is in a whole series of hospitals, this is not just one hospital, you can only imagine how CPR quality is as performed by the lay public, who may not get to practice this hardly as often. Now, we ask the next question, which is, does this rate matter? So let's say compressions are done slowly. Does it matter with regard to patient outcomes? So we looked at this, and I used the terms ROSC. I introduced this term in the first lecture. ROSC represents return of spontaneous circulation, or getting your pulse back. So ROSC is good, no ROSC is bad, and you can readily see that if patients got their pulse back, they had a mean chest compression rate that was much higher than the patients who did not get their pulse back, suggesting that chest compression rate does indeed matter and has an effect on outcomes. So once again, the way we do CPR matters quite a bit. Now, many of you may know that new CPR guidelines were released in 2010. These guidelines evaluated all of the evidence in the past 5 years, including the evidence I just shared with you, and used it as a basis for a very important change. Two changes, actually. One, for bystander CPR, for lay person, non-healthcare provider CPR, there is now the notion of hands-only CPR, no mouth-to-mouth breaths. And this is an American Heart Association guidelines approved process, or I should formally say there's an organization called ILCOR, the International Liaison Committee on Resuscitation, which is an international global body that regulates these guidelines. They have endorsed the idea of doing hands-only CPR if a layperson is unwilling or untrained in mouth-to-mouth breaths. The other thing you should know is that the guidelines have changed up an age-old mantra. It used to be that all healthcare providers learned the ABCs of cardiac arrest, meaning first you pay attention to the airway, then you check for breathing, and then you provide chest compressions. Well, that's been switched up. Now it's CAB, and this is the new mantra where first you do compressions and worry about the circulation, then you worry about the airway and the breathing. It's a small change, but a very important semantic change to focus on this notion that compressions and circulation are the most important thing in the resuscitation of a cardiac arrest patient. Now, there are many other things you can learn about when you record CPR, including the effect of CPR on defibrillation. After all, we've talked about the notion that defibrillation or electrical shock is crucial for some patients in cardiac arrest. Well, what if there's a big pause between the delivery of chest compressions and the shock? Does it matter? This is a pause before a shock. You see the compressions, bottom left-hand corner there, are stopped. The rhythm is looked at. Someone decides this patient needs a shock and they deliver a shock. This pause is 15 seconds. Is that too long, too short? Does it matter? Well, we looked at this in a methodologic way, and what you see here is a distribution of pre-shock pauses from very short to very long, and the chance of the shock actually working. And what we found was the longer the pre-shock pause, the worse the chance of the shock actually doing anything. Now, you see those pauses are sort of funny numbers, less than 10.3, 10.5 to 13.9, not sort of regular even numbers. That's because this is called a quartile analysis. We took a whole series of cardiac arrests and divided them into 4 equal portions, the same number of cases in each bar. So on the left, the tall bar there represents the quartile with the shortest pre-shock pauses, and on the far right, the quartile with the longest pre-shock pauses. And you can see a dramatic effect on defibrillation with these pauses. So what's going on here? Well, I want to leave you with this visual model, and this is a little refresher from your high school biology class. You all know that adenosine triphosphate, or ATP, is the energy storehouse of cells in your body. You can think of this like a charged battery that your cell can use to do things, including heart cells. Heart cells need ATP to contract and to make the heart beat. When ATP is used up, or when you've spent your battery, you get ADP, adenosine diphosphate. You break off a phosphate, you release energy. So that's a cycle that occurs in your body every moment. ATP is broken up to ADP and you release energy. And then ATP is restored because you eat and breathe and blood flows, moving both oxygen and glucose to cells, and you restore ATP. So that is one of the fundamental cycles of biology to provide energy to cells in your body. So that's a little bit of a refresher. And now I want to look at this in terms of cardiac arrest. You see there ventricular fibrillation. Ventricular fibrillation, as well as other rhythms of cardiac arrest, chew up ATP. The heart's energy store becomes depleted, or the battery becomes spent, if you will. This heart is energetically dead and will not beat. If you provide good CPR, you actually restore ATP by moving blood and oxygen back to the heart. And this has actually been shown experimentally. So you can restore the heart to a state where it may start functioning, or where a shock may be able to work. This may explain why pauses are so important. A long pause before a shock, your heart's not going to have ATP, and it's not going to respond to the shock. Now, those of you who are expert providers watching this course, this is clearly a little bit oversimplified. There are other factors at play as well, but it's an important model, I think, to keep in mind for one of the factors that may be contributing to why pauses are bad and why bad CPR is problematic. Now, other groups have looked at the way we perform CPR. This is a study that was done in the pre-hospital setting or ambulance setting by a large group of investigators. In this study, they looked at something called compression fraction. And compression fraction is basically the amount of time spent actually compressing the chest during an arrest event. So, if from the moment someone goes into cardiac arrest to the moment their pulse is restored or they're declared dead, compressions are given the entire time, that's 100% compression fraction. If no compressions are given, that's 0. Well, we know compressions are a good thing, so you might expect the more compressions, the better the survival, and indeed, that's what we see. At low compression fraction, survival is much worse than at high compression fraction. So again, speaking to the fact that the more compressions, or the faster the compressions, or the more dense the compressions, if you will, the better for patients. Well, I've shared with you a number of slides now on rate, frequency, density of compressions, the amount of compressions, if you will. But you remember from the first lecture that compressions involve both a rate and a depth. So what data exists for the importance of depth? Well, this is a very interesting study I want to share with you. Not done by our group, but rather another group in which animals were placed in cardiac arrest. These are pigs under anesthesia, placed in cardiac arrest. And a machine is used to deliver very uniform compressions. And the investigators asked a very simple question. Does it matter if you push harder or less hard on outcome? And they chose to compare two depths, 2 inches versus 1.5 inches. Now you might wonder why they chose this experimental design. You may recall that in 2005, the guidelines said it was okay to compress between 1.5 and 2 inches. So according to guidelines just a little while ago, both of these would be acceptable. They asked a very simple question, is that true? Are they both acceptable? So what I'm going to show you here is blood pressure in the coronary arteries around the heart in these two groups. And I'll just tell you that in the animal laboratory, if you cannot get this blood pressure above 15, in general, as a rule of thumb, your chance of resuscitating an animal are poor. Well, over 3 minutes of CPR, this was the pressure with 2 inches of depth. This was the pressure with 1.5 inches of depth. After 3 minutes, all the animals were defibrillated, and this was the survival. A dramatic difference in survival with just a ½ an inch difference in depth. Those of you who are healthcare providers listening to this, I might ask you, the last time you did CPR, how do you know you did 2 inches? Are you sure you were pushing hard enough? If you ever wondered if it mattered, these data would suggest it matters quite a great deal. Now, a little bit more on chest compression depths. This is a very large study recently published from an out-of-hospital research group, and they found a very similar thing to what's found in the animal lab. The deeper you compress, the better the chance of survival. In this case, compression depth is labeled here in millimeters. So 1.5 to 2 inches is 38 to 51 millimeters, for those of you who are in the US and need that conversion. So again, the deeper you push, the better the chance of survival. That's where 2 inches is, and you can see it may sort of top out, but we should really be making sure we push at least 2 inches, which is what is stated in the 2010 guidelines. All compression depths should be at least 2 inches. Now, what about breaths? We've talked a lot about compressions. And I showed you in a video some short time ago what the breaths look like. Well, you could imagine you could do breaths slowly, or you could do breaths more quickly. So these are two examples of tracings of mouth-to-mouth breaths, or bag valve mask breaths, if you like, if you're healthcare providers. Does it matter? Well, a study done in the pre-hospital setting by Tom Ofterheide and his colleagues in Milwaukee showed that paramedics during actual cardiac arrest events hyperventilate patients. They breathe too fast. The American Heart Association recommends a rate of 8 to 10 breaths per minute, and they ventilated at 30 times per minute, 3 times faster than the recommended rate. Now, these are well-trained paramedics who clearly are interested in saving lives. What's going on here? I think the issue is that this is an adrenaline-filled room, and they are holding a bag, so they squeeze the bag. And this has been replicated in a number of settings, so I don't mean to beat on these excellent paramedics. Healthcare providers in the hospital do it, respiratory therapists do it. Hyperventilation of cardiac arrest patients is endemic, worldwide. Big problem that we all need to focus on. Now, you might ask, is it a big problem? Well, I'll tell you that this study actually showed something a little more dramatic. In a first group of cases, they found a ventilation rate of 37. They then took this to the animal lab, simulated that ventilation rate, and found that it killed all the animals. In fact, this research publication is titled Death by Hyperventilation. They then retrained all the paramedics, and ventilation rate got a lot better. So with intensive retraining and instruction as to the importance of slowing down the breaths, these paramedics improved. I might ask you again rhetorically, in your hospital, in your EMS agency, what is the ventilation rate? Do the providers understand the importance of not hyperventilating? So I mentioned that the rapid ventilations tested in the animal lab killed all these animals. So that's a really bad thing. We don't actually have good data currently on whether rapid ventilations hurt humans, but it's certainly reasonable to assume that we should stick to the AHA recommended rate of 8 to 10 breaths per minute. And I had mentioned to you that this is death by hyperventilation. No such study called death by hyperventilation has been published on clinical cardiac arrest, although I imagine that manuscript could easily be written. Now, there's other things we can look at when we record CPR quality. One of the big things we always worry about is fatiguing. Are people getting tired when they provide CPR? It's not as easy as it looks. Well, here's another tracing which you're now growing familiar with looking at CPR tracings. And you can readily see, looking at this, that these compressions are getting shallower and shallower over time. Maybe this person is fatiguing. Well, no one had actually studied fatiguing in the clinical setting. A number of simulation studies had suggested that some rescuers do indeed get fatigued over several minutes of CPR. Our research group set to evaluate this in the clinical setting, and we looked at single rescuers providing CPR over time. And we found that over 2 to 3 minutes, compression rate did not change much. So maybe people weren't getting tired. Maybe compressions are just fine. When you looked at depth, you got a different story. Over 2 to 3 minutes, the depth did decay or decline over time, suggesting that the people do get fatigued with several minutes of CPR. As you know, the current AHA guidelines, or as you may know, I should say, the current AHA guidelines recommend switching rescuers every 2 to 3 minutes. These data support that recommendation that really we should not have unnecessary bravado when we provide CPR. If there's other people there, we shouldn't say, oh no, I'm not getting tired, I'm fine. No, we should switch rescuers every 2 to 3 minutes to get a fresh person on the chest to provide CPR. Now, obviously, if you're a single rescuer in the public sphere, this is difficult. You just have to do the best you can. But be aware that this is a tiring physical act.